Hello and good day. Today we will be discussing hematopoiesis. Our learning objectives for this discussion is to first define what is hematopoiesis, to identify the hematopoietic sites that occur in the body, define and identify the progenitor cells that involves in the hematopoietic system, to discuss the synthesis of red blood cells, including its maturation, differentiation, regulation of its production, including the role of iron, vitamin B12, folic acid, to discuss hemoglobin synthesis, and to discuss the abnormalities in red cell production. And lastly, we will also discuss the synthesis of the white blood cells, including its identification of the different types, discuss the maturation and the differentiation, discuss its function in our body, and to discuss the different abnormalities of the white cell production. So what is hematopoiesis? Hematopoiesis is a process by which blood cells are formed. It has been intensely studied for over a century using a variety of model systems. So this is actually the basis or the backbone of hematology, which we will be taking in later years. So we go now first to the red blood cells. The red blood cells are biconcave discs with about 7 micrometers in diameter and about 2 to 3 micrometers thick. The shape actually is very important for the red blood cells since because of its shape and the flexibility of the cell membrane, it can pass or it can squeeze through very small and tiny capillaries. So this is a very important characteristic of a red blood cell because without the elasticity of its cell membrane, um, increased destruction of red blood cells will be seen throughout the body. And as we all know, that the main function of the red blood cell is to transport the molecule hemoglobin. And hemoglobin in turn is very important because this is the one that will carry oxygen as well as carbon dioxide in and out of the lungs and the peripheral tissue. The red blood cells also contain large quantity of carbonic anhydrase, which will make it possible for it to carry enormous quantities of CO2 to be expelled in the lung. And another main function of the red blood cell is it is a good or the major acid-base buffer in the blood. Okay. So the concentration of red blood cells in the body vary with age, sex, and even between laboratories or even in different ethnic groups. Later in the discussion, I will also give you an example wherein a certain group of people will have what we will define as elevated red blood cell. So this is just a rough guide for the parameters of the red blood cell, hemoglobin, and hematocrit component in the complete blood count. So the red blood cell is usually between 4 to 6 in men and about 4 to 5 in women. The hemoglobin actually is measured as the concentration of the total hemoglobin in the body, which is about 14 to 17.5 in men and 12 to 15 in women. While the hematocrit is actually defined as the percentage or the percent red blood cells that is present in the body. It's about 40 to 50 in men and 36 to 45 in women. So hematocrit actually is a component of the CBC wherein um, when you separate the different components of the blood, the red cell component will be reflected as hematocrit. So meaning the red cell component in the blood is about 40 to 50% in males. But remember again, this is just a rough estimate of the values because you will see, as you've seen mga CBC na mga results, they really do have different values, and even the units that are used may be different. Okay, but these are just um, common units and the most parang rough, as again, rough estimate of the normal values. So we go now to the sites of hematopoiesis. So the production of the red cells in the body occur in different parts and in the different organs. In the early weeks of gestation or during embryonal life, primitive nucleated cells are actually produced in the yolk sac. As the pregnancy progresses, during the middle term or middle trimester of gestation, the main hematopoietic site now here will be the liver. But reasonable numbers will also be produced in the spleen and in the lymph nodes. Then, just before birth or during the last month of pregnancy and thereafter, the red cell production or the main hematopoietic site now will shift to the bone marrow. Particularly, please take note the long bones. But as the person ages, the bone marrow in the long bones will eventually be replaced by fat. Okay, so by the time the person is about 20 years old, around 20 years old, the only sites of hematopoietic production will be in the membranous bones, or what we call, or the flat bones of the body, particularly the vertebra, sternum, ribs, and ilia. I don't know if you have any experience with this, but during bone marrow evaluation or examination, the hematologist or the pathologist actually will get a sample of the bone marrow at the iliac crest. Okay, so that's the main site of where we get bone marrows for examination. Okay, but as the person gets older, more and more of the bone marrow will be replaced, and as you notice that older populations actually is more prone or usually are more anemic than the younger ones because the hematopoietic sites of these individuals actually are continuously being replaced by fat. So in the lower left, this is the figure lifted from Guyton. You will see the relative rates of red blood cell production in the bone marrow in the different stages, uh, different bone marrow of different bones at different ages. As you can see, um, before 30 years old, it's primarily really in the long bones. And then 30 years and after, it will plateau between the vertebra, sternum, and rib. Okay? So now we will be discussing the potential or pluripotent hematopoietic cells. So these cells are actually stem cells. So the blood cell begin their lives in the bone marrow from a single type of cell called the pluripotential hematopoietic stem cell, or the HSC or the PHSC, from which all of the cells in the circulating blood are eventually derived. Okay. Its most important property is actually self-renewal. So in the process of self-renewal, it is able to divide and generate more stem cells. It is crucial to the function of the HSC because because of self-renewal, it will maintain a long, steady state pool of HSCs in the adult bone. One of the important pathways that will regulate its growth and division include the Notch pathway, the sonic hedgehog pathway, the WNT beta-catenin pathway, and the Janus kinase 2 pathway, or the JAK2 signaling pathways. So these pathways actually regulate the production and the self-renewal of our pluripotent stem cells. Okay, so this is what I've been talking about. The HSC will actually divide into two daughter cells. One of the daughter cell will remain on the stem cell pool. So this one will remain in our body and will stay dormant until when we need it or when it is activated. So when does this activate? So actually the main um, active instances is actually if disease states wherein we need more of a particular blood cell, or if we need more production from our bone marrows, this will be activated, or in abnormal or malignant states wherein this is abnormally signaled to mature and to progress. Okay, so this is a daughter that will remain as a storage pool of stem cell. So after this is acted upon by our signaling pathways, it becomes committed. Okay, so when it becomes committed, it can either be CFUS, colony forming unit in the spleen, or a LSC, a lymphoid stem cell. So that's the first committed lines that we will see in the body. So from the CFUS, this is now the line of blood cells that we see in the blood, such as our erythrocytes under CFUE, or the colony forming unit erythrocytes, our white blood cells that is under CFUGM, colony forming unit granulocytes and monocytes, wherein the granulocytes, monocytes are formed. And then the CFUM, or the colony forming unit megakaryocytes, where our platelets will eventually arise. On the other side of the committed cell is our lymphoid stem cell, wherein we will see our beloved lymphocytes. Okay, as you notice in the diagram, separate ang committed cell or committed mother cell for the lymphocytes and all of the other um, blood cells in the body, in the blood. So with this note, this is also because of this, leukemias, which I will discuss later, will also be divided almost the same as this. So we have leukemias that affect only the lymphocytes. We call that acute lymphocytic leukemia, or leukemias that affect the white blood cells, or granulocytes, erythrocytes, and megakaryocytes. They are all under myelogenous leukemia. Okay, I will discuss them later on. So that's the concept of our pluripotential hematopoietic cells. So these, their production is actually regulated by two main inducers, are growth inducers and differentiation inducers. So please take note that they are different. Growth inducers actually promote the growth, the reproduction of each of the stem cell. So there are actually been four major inducers that have been discovered in the blood, but I will mention interleukin-3, which acts on all of the different types of the committed cells in the blood. This is different. Growth inducers are different from differentiation inducers, wherein differentiation inducers will cause one type of committed cells to differentiate. Okay? So for example, in the committed colony forming unit GM, or granulocytes and megakaryocytes, once the differentiation inducer acts on that particular committed cell, it will push the cell into becoming a particular mature cell in the future. So it will either push it towards the erythrocytic lineage, it will either push it to the WBC granulocytic lineage, or it will produce it or push it to produce platelets eventually. So that's the difference between differentiation inducer and growth inducers. Growth just promotes growth and reproduction. And these inducers are actually also controlled by factors outside the bone marrow. Okay? So once our colony forming unit has been acted upon by our growth inducer, so it will grow, it will reproduce, and then the differentiation inducer will act upon it, making it only limited or committed to one cell line. So we will go now to the erythrocenic lineage. Okay, so in the erythrocenic lineage, its main mother cell is the CFUE, or the colony forming unit erythrocytes. So from that CFUE, once it is still acted upon by the differentiation inducers, it will now become what we call the proerythroblast or the normoblast. So this is the first identifiable or the most immature cell that can be identified in the red cell series. So it, as I've stated, it matures from the CFUE stem cells. It is also the largest of the erythroid precursors and has the highest content of RNA. It undergoes two mitosis and becomes two basophilic normoblasts. So this is an actual example of a normoblast, a pronormoblast or proerythroblast in the bone marrow. It's actually a large cell. This is an example. This is an RBC. It's a very large cell with a high NC ratio. So meaning, when we talk about high NC ratio, it means the nucleus is as big as a cytoplasm. Immature cells, this is a rule of thumb. Immature cells will always have a high NC ratio. So as it matures, as the cell matures, that nucleus will eventually shrink. Okay, lowering the NC ratio. So you have more cytoplasm than the nucleus. So in contrast to erythrocyte, um, to immature cells. And I want, before that, the next series, as the proerythroblast matures, it becomes the basophilic erythroblast. So I want you to remember that in the erythrocenic lineage, the main goal of the RBC, or the erythrocyte actually, from mature down to erythrocyte, its main goal is to remove the nucleus of the cell. Okay? I want you to remember that at the back of your mind. As the cell matures, or as the erythrocyte production ensues, its main goal is to expel the nucleus. Okay? So from the proerythroblast, we are now to the basophilic erythroblast. So this is somewhat smaller, has coarser chromatin, and stains a deeply basophilic cytoplasm, owing to the abundance of the RNA in the cytoplasm. Another note that I would give you is that when using hematologic stains such as Wright stain, when we say basophilic will appear blue on the stain, and this is usually due to abundance of a basic component. Okay, that's why basic, while when we say eosinophilic, So meaning it is attracted to the eosin component of the stain. It it actually correlates to red or more pinkish. Okay, I think we will discuss that later on in hematology, I think, or in histo. So, but in our discussion, when I say basophilic, it means blue. Okay, it the basophilic in erythroblast actually again. So this is a basophilic erythroblast. It has a more coarser chromatin, although the NC ratio is still moderately high. Um, the cell actually is much more smaller than the immature one. As you can see, the cytoplasm is still very deeply blue. That it owes it to the RNA content in the cytoplasm. Okay. Next, we go to the polychromatophilic erythroblast. So, in here, the first evidence of hemoglobin production becomes visible in the cytoplasm. Hemoglobin, as we all know, has a reddish color. So, it acts on the acidophilic part of the stain, so it becomes reddish or pinkish in color. So since you still have RNA in the cytoplasm, you now have production of hemoglobin. So the two colors will mix. So this cell, that's why it's called polychromatophilic, because in different stages, it will have different shades of blue and pink, sometimes gray, magmix siya. Okay, so it has a varying shade of gray to pink because of the varying amounts of RNA and hemoglobin on its cytoplasm. So the nucleus condenses, so it now becomes much more smaller and undergoes the last mitosis to give two daughter cells. Okay, remember, this is the stage in the erythroid series that undergoes the last mitosis. So this is a polychromatophilic erythroblast. As you can see, it's much more pinkish than the basophilic erythroblast, but it's still not quite there yet. Similar to the adjacent red cell. Look at the red cell. It's pink. Diba? The red cell is pink. This red cell has a lot of hemoglobin, while this one is still starting to produce hemoglobin along with abundance of RNA in its cytoplasm. As you can now see, the nucleus is much more smaller, much more condensed or compact. So after the polychromatic or polychromatophilic erythroblast, the last stage, the last stage of the erythroid series that will contain a nucleus is the orthochromatic erythroblast. Okay, in here, mitosis is no longer possible. The cytoplasm becomes more pinkish because of the abundance of hemoglobin, but still bluish tinge because it still has some um, RNA in its cytoplasm. So this is now the last stage wherein we will see nucleus in the red cell precursor. So the nucleus here is actually very condensed and ready to be extruded out. So as this cell passes through capillaries or mga blood vessels, the nucleus will actually be removed eventually. So, for example, this is a capillary. This is a capillary. So, there is a space between. As the cell moves, as the cell moves out, moves in and out of the capillaries, mabilin ang nucleus. Okay, so eventually, it will become unnucleated. Okay? And as you can see, the size of the cell is actually more closer na to the immature red cell. So once it removes or it loses its nucleus, it becomes now the reticulocyte. The reticulocyte is actually or has almost the same color of cytoplasm of your orthochromatophilic erythroblast, except that it does no longer have the nucleus. Okay, this is the first unnucleated um, ancestor of your erythrocytes. The cytoplasm is still pinkish or bluish gray as a result of the retention of RNA content. However, when RNA stops, hemoglobin synthesis continue, it will lose its RNA and mitochondria in the cytoplasm, giving the characteristic salmon pink color of the red cell. So these erythrocytes are actually parang intermediate phase lang of the the reticulocytes are actually intermediate phase of the erythrocytes. So they're short-lived. They remain in the marrow stroma for 1 to 2 days before being released into the blood, where they will remain as a reticulocyte for only about 1 day. Okay. So what's the importance before we go? I'll show you a reticulocyte. So this is a reticulocyte. Well, the color is slightly different because I got this. This is not from the book. Usually, the cytoplasm of this reticulocyte, or otherwise known as polychromatophilic erythrocyte, is usually pink-gray, no more nucleus, so no more NC ratio. Okay, what's the importance of the reticulocyte in the blood? So, diba I mentioned earlier that it remains in the bone marrow for about 1 to 2 days and circulates in the blood for about 1 day before it becomes an erythrocyte. So in disease states, for example, um, the patient is very anemic. We want to know what's the cause of the anemia. Okay, what's the cause of the decreased red cell count or hemoglobin count in the body? So reticulocyte can be used as a test or an adjunct to our investigation because when measuring reticulocyte, we're actually also measuring the capability of the bone marrow to produce red blood cells. Okay? In an event or in a disease state that when the patient does not have has decreased red cell or decreased hemoglobin content, we think of two things. When um, Two things with reticulocyte. Is the reticulocyte increase or is the reticulocyte decrease? What does it mean? If you have anemia and your reticulocyte is increased, meaning your bone marrow is compensating or trying to produce more for the body to compensate the loss of the red blood cell. Where if you have anemia or if you have low red blood cell or low hemoglobin and you do not have an increased reticulocyte, what does it mean? It means that your bone marrow is actually not compensating properly to the insult. Okay? So that's it's a good parameter that should be ordered or that is also ordered when evaluating or assessing um, bone marrow compensation of the blood in response to anemia. Okay, I will discuss that later on. So that's the importance of reticulocyte. And during disease states, we will see more of this in circulating in the body. It will have a different stain than the usual stain that we use for red blood cells to accentuate the bluish tinge color. So actually what we do is we count it in the smear and we count how many reticulocytes it is. Is it with red cell and then convert it into percent. Okay? Said after, okay, it doesn't have the mitochondria, it doesn't have RNA, it now becomes erythrocytes. Now, I mentioned erythrocytes earlier, right? It's a biconcave disc They do not have a nucleus, they do not have a mitochondria or endoplasmic reticulum, but they do contain enzymes that will metabolize glucose and small amounts of ATP. Diba? RBC is very amazing because it does not have the organelles that is usually seen in other nucleated cells. Okay? But it is still capable in metabolizing glucose, and it can form varying amounts of ATP or energy. Okay? That small little thing actually has a lot of things going on inside. So this is a normal erythrocyte. So as I mentioned, the cytoplasm, the typical cytoplasm or the color would be what we call a salmon pink or some more on pinkish color. Okay, that's normal. So as you can see, it's usually darker in the periphery and more lighter in the central area. This this is how it looks like because remember its shape. It's biconcave shape. If we look at it side view or on the side, we will see like this. Okay, that's biconcave. So it's more, the color or the stain is more prominent in the periphery because the periphery is much more thicker, diba, than the central portion. So that explains why it has a lighter center and a more darker periphery. Okay, so that explains it. So, so we know now how the red blood cell matures. So now we will be discussing the regulation of its production. So in this slide, I want to um, show you the concept of tissue oxygenation and EPO. So any condition that causes the quantity of oxygen transported into the tissue to decrease will also increase the rate of red cell production. Okay? When person becomes extremely anemic as a result of either any condition, if the bone marrow is still okay, it will produce large quantities of red cell. So the principal stimulus, so from that statement, the principal stimulus of red cell production in low oxygen state is actually the circulating hormone called erythropoietin. Okay? You should remember erythropoietin. So erythropoietin is a glycoprotein that is produced almost exclusively in the kidney. Okay. Erythropoietin is very important in a sense that even if you are hypoxic, or meaning um, if you have very little oxygen in your body, without erythropoietin, you will not or you will not mount an increase in red cell production. Okay, so erythropoietin is very important because in its absence, hypoxia has little or no effect to stimulate red cell production. But when erythropoietin system is functional, hypoxia, in the presence of hypoxia or decreased oxygen, it will cause a marked increase in erythropoietin production in the blood. Okay, that will enhance red cell production until hypoxia is relieved. So actually, they are complement each other. Okay, in producing or increasing red cell production, but still EPO is still the main stimulus. Okay, so let's go to the diagram on the right side. So again, this is EPO. It is produced by the kidney. Okay. On the next slide, I will discuss what's the main effect of EPO in the body in terms or in relation to hematopoiesis. So when when we have disease states that will cause hypoxia or decrease tissue oxygenation, this in turn will stimulate erythropoietin. So since kidney is the main site of its production, one of the most powerful stimulus or stimuli for its production is actually renal hypoxia. So, okay, if you have decreased blood that comes to the kidney, that's one of the most powerful stimulus because it is produced there. So when it becomes stimulated, so the kidney senses, there is low in oxygen now, let's produce EPO. So the EPO will now then act on your hematopoietic stem cells to increase and to hasten the production of your red blood cells. Okay, so production of the red blood cells will then correct the decrease in oxygen levels in the blood. Okay, so since it is produced in the kidney when the patient does not have kidney anymore, EPO can still be produced in some unknown parts in the body and also in the liver, but the response, the bone marrow response, or the increase in EPO actually is not that great in compared to when you still have your kidney. So I don't know if you also heard this. This is also used by this is what cyclists use to boost their stamina. They usually inject EPO. So when you inject EPO, you have increased red cells. So when you have increased red cells, you have more capacity for oxygen. You have increased oxygen capacity in your body. So mas more ang stamina. So dili kayo sila hamuson. So I think this is one of the more prohibited drugs. But that's what they call, I don't know if you heard some news, sa mga cyclists, that's what they call doping. They are doping with EPO to boost their stamina. Okay? So, as I mentioned earlier, the important effect of erythropoietin is actually to stimulate the production of pro-erythroblasts. Okay? And hematopoietic stem cells in the bone marrow. So, in the presence of high EPO levels, this causes cells to pass more rapidly to the different erythroblastic stages than they normally do, speeding up the production of new red blood cells. Okay? So another important element to the production of red blood cell is vitamin B12 and folic acid. So, because of the continuing need to replenish red blood cells, the erythropoietic system is actually among the most rapidly growing and reproducing cells in the body. So, important for the final maturation of the red blood cells are the two vitamins that I've previously mentioned. Both of them are essential in the synthesis of DNA because each is required for the formation of thymidine phosphate, one of the essential building blocks of DNA. So lack of either B12 or folic acid causes abnormal and diminished DNA, so causing a failure of nuclear maturation and cell division. So in patients with vitamin B12 or folic acid deficiency, its main effect on the blood actually is an abnormal nuclear maturation. So, as you can imagine, the nucleus will be immature. The nucleus will be large and immature while your cytoplasm will become mature. So now there is imbalance. So that's what we call nuclear cytoplasmic asynchrony. Okay? So the nucleus is large and immature while your cytoplasm is actually mature. So imagine your nucleus is at the pronormoblastic stage, but your cytoplasm is looking like polychromatic philic erythroblast. Diba? Pink na siya, but the nucleus is still immature. So there is asynchrony, okay? Because cytoplasm continues to mature while the DNA is actually lagging behind because of the lack of vitamin B12 and folic acid. So another effect of this in the bone marrow on the hematopoietic system is that the cells or the erythroblastic cells will actually become larger than normal. So we call them macrocytes. Okay? So these macrocytes will actually have very flimsy membrane and often have irregulars like super large cells um, and appear oval instead of the usual biconcave disc. Okay? So again, remember the importance of the biconcavity of the bread cell. When that is lost, the cell membrane actually will be very, very fragile, so it is prone to destruction in the smaller capillaries. So now we go to the formation of hemoglobin. So synthesis of hemoglobin begins in the proerythroblast and continues even into the reticulocyte stage of the red blood cell. Therefore, when they leave the bone marrow and pass into the bloodstream, they continue to form minute quantities of hemoglobin for another day or so until they become erythrocytes. So remember, mature erythrocytes no longer produce hemoglobin. So these are the three main components of your hemoglobin. So it's actually named after them. You have the heme or the heme component and the globin component with iron. Okay, so the globin actually gives it this helical shape of the polypeptide molecule. So as you can see here, the globin is the globins are helical shaped, wherein the iron and the heme group are inserted. Okay. So those are pockets. This is the pocket of heme and iron, pocket of heme and iron. And actually, those pockets of heme and iron, those are where the oxygen will insert. Okay. So again, the main function of hemoglobin is to combine with oxygen in the lungs and release the oxygen in the peripheral capillaries. So this function is actually very important. You have to know this, is that it must be able to easily combine with oxygen, but it must also be easy for it to release oxygen. Okay? It's not only about getting oxygen, but it must also release oxygen at certain circumstances. So for example, when the oxygen level or oxygen pressure increases, this is seen in the environment of the lungs because that's where all of the oxygen is in the body or concentrated. In that environment, a certain trigger of the oxygen, of the hemoglobin, will then get or bind to four the four oxygen molecules to each of the heme molecule. Diba? You have four heme molecules which can bind to one oxygen each. Okay, in an environment that has high oxygen pressure or levels, such as the lungs. But as it goes into the body, it will go to the periphery, the organs who need that oxygen. It will sense now that there is decrease in oxygen levels or pressure. there will be conformational change in the hemoglobin molecule wherein it will now unbind or release the oxygen molecules into the tissue who needs it. That's very, very important kasi there are some abnormal hemoglobins wherein it binds the oxygen but it will no longer release it. So it's very ironic kasi you're well oxygenated but your tissue are starving. So they are not oxygenated properly because the hemoglobin does not release your oxygen. Okay. Another good example is carbon monoxide poisoning. Carbon monoxide poisoning is wherein you have your carbon monoxide. Carbon monoxide actually is much more favorite ni hemoglobin kaysa ni oxygen. So when you inhale carbon monoxide, the hemoglobin, instead of binding with oxygen, it binds to the carbon monoxide. Actually, it actually has affinity for carbon monoxide 200 times more than oxygen. So ganyan niya ka-love si carbon monoxide. So that's what kills the person. Although you have normal levels of hemoglobin, you have normal levels of RBC, but your hemoglobin is picking up the wrong molecule. That's what kills the organs and the patient. So that's why ang treatment sa carbon monoxide poisoning is a oxygen chamber. So they put the patient in a chamber with 100% O2 so that ang pressure ng O2 is very, very high. There, si oxygen, si hemoglobin, it will release ng the carbon dioxide and pick up oxygen. Okay, so that's a very important thing for hemoglobin. Okay, and also each hemoglobin is capable of combining with 1.34 ml of. So again, we know that it has three components: the heme, the globin chain, and the iron. So first, we discuss them. The formation of each. We'll discuss the formation of each briefly. So, heme synthesis actually occurs in most cells of the body, but they are most abundantly seen in erythroid precursors. So, in the formation of heme, the first component is actually succinyl-CoA plus glycine, okay, which will then form a pyrrole molecule. And the combination of the four pyrrole molecules, it will undergo several enzymatic changes. Ang end product would be your protoporphyrin 9. This protoporphyrin will now bind to the ferrous form. Okay, remember that ferrous form of iron, creating your heme molecule. Okay. So any disruption of the heme synthesis or abnormalities or absence of enzymes in the heme pathway is the disease that we call porphyria. Okay? So diseases or abnormalities in the heme synthesis is actually called porphyria. Lead poisoning actually inhibits the last enzyme in the formation of heme. Okay? And the catabolism or the degradation of heme is actually done or happens in the blood, wherein it will be excreted as bilirubin in bile, as urobilinogen in urine, and stercobilin in the GI tract. Okay? So, for example, in disease states where there is this increased destruction of the red cell, you will have increased destruction or release of heme in the blood. You will see it in the urine, the stool, and even the bile. So usually those patients will have very intense or increased levels of urobilinogen and stercobilin and bilirubin, stercobilin in the GI tract. Okay. So for the globin part, so since the globin is a polypeptide, so the synthesis occurs in the cytoplasm of the normoblasts and the reticulocyte. Okay, so this was this is one of the earlier lectures that you have or exercises you have, the formation of protein. So where does it occur in the cell? Do you think? So this formation occurs in the cell, and there are about 4 globin chains that are produced in the adult. Okay? Adult ha, adult lang. So they can be designated as alpha chain, beta chain, gamma chain, and delta chain. So since there are 4 chains, each hemoglobin will have a combination of 2 chains with 2 molecules each, as seen in the picture. In an adult, ang combination ng globin in an adult is actually 2 alpha and 2 beta chain. Okay? This is in contrast to your fetal hemoglobin. As you can see, fetal hemoglobin is composed of 2 alpha and 2 delta. There is also, you ask me, what's the importance? There is importance because fetal hemoglobin will actually has much more higher affinity in the oxygen than your adult. Why does it need to have higher affinity for oxygen than adult? Because in fetal hemoglobin or in the fetus has to compete for oxygen with the mother. So dapat mas abtik siya mag-get sa oxygen than the red cells of the mother. Compared to the adult, na chill lang, get the hemoglobin, there's no competition. Okay, so that's importance of different globin chains. But I want you lang to remember now is that an adult, the most common hemoglobin is hemoglobin A that is composed of 2 alpha and 2 beta. Okay? So any abnormalities with the production of the globin chains are what we call as thalassemias. So if you have it is a mutation in a gene that will cause decrease or absent synthesis of the globin chain. So in thalassemia, we call it alpha thalassemia if it does not, or if the abnormality is on the alpha chain, or beta thalassemia if it occurs in the beta chain. Okay? And next is iron. So iron, what's the importance of iron is that ferrous iron atoms have 6 coordination bonds, 4 to the pyrrole, nitrogen of heme, 1 to the globin chain, and 1 that is irreversibly, again there's the term, reversibly bound to oxygen. So it's important because iron atoms can bind loosely with 1 molecule of oxygen, totaling the number of oxygen carried by the hemoglobin into 4 to 8. Okay, so you have 4 oxygen that binds to the heme, and you have another 4 that binds to the iron. So you now have a total of 8 oxygen molecules being carried by hemoglobin. So that's the importance of iron in the blood. Okay. So I think I will not discuss the iron in transport and metabolism of iron. Right, it will be too much now for you, but I'm just showing this that actually iron is being recycled in the body. Okay, and there are some disease states wherein there is decrease in iron also causing anemia, and that's what we call as iron deficiency anemia. So we go to the abnormalities of the red cell lineage. Here are the normal values that I've showed you earlier. So now we will be discussing anemia. So anemia is actually a condition of having a lower than normal number of red cells or lower than normal quantity of hemoglobin. So when we talk about anemia, it's not just about the number of red cells
present in the body, but also the quantity of hemoglobin. Okay, remember that. Remember the main function of the red cell is to carry hemoglobin, which in turn carries oxygen. So it helps in the oxygenation of the different organs and cells in the body. So anemia diminishes the capacity of blood to carry that oxygen. Okay, so patients with anemia will usually have very vague, non-specific symptoms. So it usually relates to the amount or the degree of the severity of the decrease in RBC or hemoglobin. So patients may usually feel very tired, they fatigue easily, they appear very pale, or may develop palpitations. And some patients may actually become or have a shortness of breath. So in this image, I am just showing the different causes of anemia. So we have established what do we mean by anemia. So anemia can be caused by anything. So this is a good guide for you to know the different causes. So it may be due to production defects. It can be maturation defect. It could be due to survival. So there is shortened survival of the RBCs. They may be increased sequestration of the RBCs, and or it may be due to increased blood loss. So we will define this. So the first is production defects. So production defects means that you have a problem with either the bone marrow or for example, the erythropoietin. So one good example of a production defect that affects the bone marrow is aplastic anemia. So aplastic anemia actually is caused by exposure to high dose of high toxic chemicals, autoimmune disorders, administration of drugs such as chloramphenicol, or even malignancy that occupies the bone marrow. So what's important in aplastic anemia is that it does not affect only the erythrocytic lineage, but affects everything. Kasi you're killing it in the source. Eh. You're diminishing the production, the factory site. So all of your parameters will be low. You have low platelet, low WBC, low RBC. Whereas if you have problems in the kidney, I think I've discussed this earlier, like for example, patients who have chronic kidney disease or patients who have lost most of their kidneys or any renal damage will decrease what? Will decrease the production of the very important stimulus for RBC production, which is your EPO. Okay, so those are good examples of production defects. Next is we go to maturation defects. So I've also mentioned this earlier. Um, Vitamin B12 and folic acid is important in the synthesis of DNA in a cell. So not only the red cell, but all of the all of DNA synthesis in the body. Vitamin B12 and folic acid are important. So when we're talking about the hematopoietic cells, the main effect here is that there will be, I mentioned earlier, nuclear as cytoplasm asynchrony. You have immature nucleus with a normal mature cytoplasm. So a good example of this cause of anemia is megaloblastic anemia. So megaloblastic anemia um, produces a slow reproduction of erythroblasts in the bone marrow. Then there is nuclear and cytoplasmic asynchrony, and it can be due to either pernicious anemia, which is a defect, or there is absence or deficiency of the intrinsic factor. Intrinsic factor helps or is important in the absorption of vitamin B12. So if you can imagine, you have no intrinsic factor, you cannot absorb the vitamin B12, leading to vitamin B12 deficiency. Another cause of vitamin B12 or folic acid deficiency is the intestinal sprue, wherein small intestine cannot absorb both folic and vitamin B12. Okay, so, but these examples are not pretty normal. Um, a good example in vitamin B12 or folic acid deficiency is infection by your fish tapeworm or Diphyllobotrium latum. So in that infection, the parasite itself competes with the body for vitamin B12. Okay, so I gave you three. Another is nutritional defect, nutritional um, poor nutrition status, or patients who does not eat that well. Pero between vitamin B12 and folic acid, if you stop um, ingesting vitamin B12 or folic acid from your diet, with vitamin B12, you have enough stores to last you for at least 3 years. Okay? Kasi vitamin B, there is lots of vitamin B12 stored in the body. So when you stop eating vitamin B12, anemia will ensue if you don't eat any vitamin B12 or take any supplements for about years pa. But with folic acid, it is quite the opposite. If you have stopped ingesting or have an increased consumption of folic acid in the body, you may produce megaloblastic anemia or deficiency in folate for a few days. That's why, remember, in pregnant women, diba, one of the important supplement that they are asked to take is folic acid supplements. Then again, because in pregnant women, they have increased metabolism, and of course there is a baby, so there is an increased requirement, and it doesn't really, sometimes the mother cannot compensate for that. So please, so your assignment, I will include that in the discussion. What are the sources of vitamin B12 and folic acid? So next we go to the survival defects. Survival defects, by the name itself, you have decreased survival of your RBC. So what a good example here is those anemias that are hemolytic, meaning the red cells are destroyed in the blood. So many of these are hereditarily acquired. So the red blood cells here are very fragile and that easily rupture as they go through capillaries, especially through the spleen. So examples here is your hereditary spherocytosis, sickle cell anemia, and erythroblastosis fetalis. Okay? And this one, extrinsic cause of decreased survival defects. This diagram actually shows autoimmune diseases wherein an antibody or a complement attaches to the RBC that will cause it to lyse or to be destroyed. So survival and sequestration is actually increase in the destruction of the RBC by the spleen. So it is caused by also a disruption by, one good example is the RBC's cell membrane is disrupted. So parang almost similar siya with the survival defects. So one good example here that I've mentioned in survival defect is the hereditary spherocytosis. In hereditary spherocytosis, the cell membrane becomes very spherical. So it's no longer the perfect biconcave shape does it have. So what is the importance? So I've been mentioning this earlier, the importance of the biconcavity of the red cell, kasi without it, it cannot withstand the forces, compression forces in the capillaries. So imagine as it passes through very, very small and very tight spaces, the cell membrane is no longer flexible enough. So as they pass through those spaces, they rupture. Okay? Or if they do not rupture, they become deformed. Once they become deformed, the RBCs become deformed, they will be eaten up or sequestered by the spleen. Remember, I did not mention this earlier, but spleen is a graveyard of your red blood cells. Okay? Si spleen is very maarte. It doesn't like ugly red cell. So if there's any problems with the red cell, it thinks that the red cell is ugly, it will take it off the circulation. So another good example here is sickle cell anemia. So sickle cell anemia is an abnormal type of hemoglobin. Okay, so what happens is the hemoglobin is abnormal. So when it is exposed into areas with low O2, such as in the peripheral tissues, it crystallizes. So imagine if the red cell and its hemoglobin component inside crystallizes, it becomes very stiff. So it is called sickle cell because it will have a parang like, like that ang shape. Sickle. That parang elongated. Oh, that's a sickle cell. So when that happens, again, when it passes through the very tight spaces of the capillary vasculature, it hemolyzes or it ruptures. Pero if it survives gani, the vascular beds, it becomes deformed and abnormal, and then the spleen will eat it or remove it from the circulation. Okay. Next is, I think one of the most common causes is blood loss. So in acute blood loss, if it is immediately corrected, RBC returns to normal within 3 to 6 days. That is, if the compensatory mechanism of the bone marrow and kidney is okay, so normals will return 3 to 6 days. Of course, if you have blood loss and both of these are not functional, so it will not be corrected. Then another cause would be chronic blood loss. So this is common in patients who have like stomach ulcer, wherein the ulcer bleeds all the time. It's the blood loss is not severe enough that you will notice it, but as time goes on, the body can no longer. So you're always bleeding in small amounts, and then you cannot absorb enough iron to compensate for that loss. So what happens is um, it could present with an iron deficiency anemia or anemia of chronic disease or chronic blood loss. So I guess that's a good general overview of anemia. I think we will discuss this later on in hematology. So this is a table lang of the ones that I discussed. This one, I've already discussed this. Could failure abnormalities in vitamin B12 and folic acid absorption. So it could be due to pernicious anemia, wherein you cannot absorb vitamin B12. I guess I wrote it down here. The sources of your vitamin B12 is or are. Oh, I didn't. Sorry, I didn't include it here pala. These are stored pala in the liver and released slowly as needed. And this is what I've mentioned earlier. The RDA is only 1 to 3 microgram. So normal storage in the liver and other body tissues is about 1,000 times of that. So when you stop eating vitamin B12 rich foods, you could survive without having megaloblastic anemia for years. But with folic acid, that's a different thing. So we go now to the opposite of anemia, polycythemia. Polycythemia actually is defined as an increase in the red cell count above the normal value, so above normal. So there are actually three types. You have first the polycythemia vera or erythemia. So actually this is a um, disorder wherein there is mutation in the JAK2 gene. Can anybody remember where I mentioned JAK2 gene? JAK2 gene is important in your it is involved in the signaling of your hematopoietic pluripotential stem cell. So, because of this mutation in your JAK2 gene, the progenitor cells can no longer stop producing red cells. So, there is continuous production even though there is no stimulus. Okay? So, this results in an increase in hematocrit. Diba? Because you have an increase in red blood cell count. So, therefore, you have increase in hematocrit percent. Kasi mas marami na yung red cell mo than the other constituents in the blood. Okay? So, therefore, the total volume will be increased. So, what happens here is that blood flow will become sluggish. So, this may affect what system? The system discussed last week, your cardiovascular system, diba? So your heart will have to work twice as hard to pump sluggish blood. So eventually, there are mga consequences in other systems, particularly in your cardiovascular system. So because there's also increase in red cell, the complexion of these patients become bluish cyanotic. This one compared sa normal. Okay? So this is again caused by a mutation in the JAK2 gene. Question, is it a malignant process? Actually, no, it's not a malignant process, but patients usually will be required to do phlebotomy sometimes every month, sometimes every 3 months, depending on their hematocrit count. Okay? So that's a primary treatment. You just have to do phlebotomy at least to relieve or to decrease the total hematocrit count. So it's like donating blood, but the blood won't be used actually. It won't be transfused to other patients. We go to the second type of polycythemia, which is secondary polycythemia. So secondary, so meaning there is a primary cause, and the most common primary cause of an increased red cell count is, of course, hypoxia. So if there's too little oxygen in the breathed air, such as in high altitudes, the patient may produce a significant or may produce a slight increase in the normal red cell count. And of course, in patients who have cardiac failure, okay, RBC is normal, hemoglobin is normal, but your heart cannot pump enough blood. So your kidneys would think, the kidneys would think na you're hypoxic. So, diba? Remember, what's the stimulus for the EPO production? It's tissue hypoxia, especially if the kidney. If you do not have enough blood because your heart doesn't pump enough blood or is weak na, your kidney will think na, the body needs more EPO. So, it produces EPO, it produces red cell, it produces much more red cell to compensate for that hypoxia. But of course, we know that the primary cause is not the blood or the RBC itself, but because of cardiac failure. Okay, but in secondary polycythemia, the red cell does not rise to more than 7 grams or 7 grams per dl. In contrast to polycythemia vera, it will really go very high. I've seen patients na moabot og 60% ang red cell. Okay, di ba normal in male is 50. Okay. So, physiologic naman polycythemia is actually a normal phenomenon or normal process, especially with patients who are living in high altitude places like 14,000 to 17,000 feet. So, kaya 'di ba, I've mentioned na the normal values of each of red blood cells actually depend on age, sex, ethnicity, and of course the instrument that is used to detect or to measure it. So in natives, if our normal is between 11 to 14 or 12 to 15 grams per dl, and RBC count, um, in the natives, that would be anemic na for them because they live in high altitude areas, so they have to compensate more because the air there is very thin, or there is low oxygen, low O2 pressure. Okay, so similar din siya with secondary polycythemia, would generally rise into 6 to 7. So next we go to the next cell line, white blood cell. So the white blood cells or leukocytes are actually the mobile units of the body's protective system. There are 6 types of white blood cells normally present in the blood, and I will be discussing a little bit of them in the succeeding slides. So this is the pluripotent or the committed stem cell that will produce your leukocytes. So it may go to the route of a lymphoid series or the myeloid series. In the myeloid series, it may become the granulocytes, megakaryocyte that will produce your platelets, erythrocytes that we discussed earlier, or the mast cells. So I won't be discussing the thrombocytes because I think it will be too long na, and I'd like to discuss them in the hemostasis part of your discussion. So now we focus to the granulocytes and mononuclear leukocytes. So again, there are different types of leukocytes. So when you say polymorphonuclear leukocytes, it means we are talking about the neutrophils, eosinophils, and basophils. So it is called poly because they appear to have many nucleus. But in reality, they are called poly because their nucleus are segmented. So you would think na marami siyang daghan sila, it has plenty of nucleus. But actually, it's just one nucleus, but they are segmented. So I'll show them later. Okay? They are also called granulocytes because they produce granules. These granules are important in distinguishing your neutrophil, eosinophil, and basophil. And they are involved in acute inflammation. While your mononuclear leukocytes are called as such because they appear to have a single nucleus, mononuclear. And they are usually agranular except for few occasions, and they are more involved in chronic inflammation. So the white blood cells or leukocytes are also produced in the bone marrow except in some lymphocytes that I will discuss later. So granulocytes and monocytes protect the body against invading organisms, particularly ang mga bacteria. And they do that by ingesting the offending agent or by phagocytosis. And then the lymphocytes and plasma cells, I'll discuss plasma cells later, mainly function in connection with the immune system. So the early differentiation of the pluripotential hematopoietic stem cell in different types of committed cells. So aside from the cells committed to the erythrocytes, let's focus now into the two major lineages of white blood cells. Again, the myelocytic, this group, the myelocytic, this group. Again, I have to erase this. The myelocytic, this group, and the lymphocytic, this group. Okay, so we'll be discussing each. So from your commit, so for the differentiation of the white blood cells, they can be divided into the myelocytes, which includes your neutrophil, your eosinophil, basophil, and monocyte, and the other side, which are the lymphocytes. Okay, so let's focus to the myelocyte. The earliest identifiable cell is the myeloblast. So myeloblast are cells with a very large nucleus and very scanty cytoplasm. The second identifiable cell is now the promyelocyte. So in promyelocyte, what's special here is that this is where the production of azurophilic granules or the primary granules begin to appear. So in this, when you already have azurophilic granules in the promyelocyte, it means that this cell will become neutrophil. Okay? But if it does not have azurophilic granules in its cytoplasm, it may still become eosinophil or basophil. Okay? So the subsequent stages of maturation in the myelocytic lineage will now be based on the production of what type of granules. Remember, in erythrocytic series, the main goal of the mga normoblast and erythrocyte is to remove the cytoplasm. In the myelocytic series, they have two goals in life. First is to segment their nucleus, and the second is to produce the granules. So between the nucleus and the cytoplasm, which contains the granules, which do you think would be the basis for us to identify if it is a neutrophil, eosinophil, or basophil? It is the granules. I just mentioned it. Okay? So remember that. Promyelocytic stage. So this is the myeloblast. This is the promyelocyte. It will now divide. They will now identify themselves as either a neutrophil, an eosinophil, or a basophil. This one. Based on what again? Based on the production of granules. So these are now the next steps of maturation. So after promyelocyte, we will now have myelocyte. So this is the last stage that is capable of mitosis, and this is where the appearance of secondary or specific granules comes into play. So what's the importance of your specific or secondary granules? It is the secondary granules that will define that cell to be a neutrophil, eosinophil, or a basophil. Okay, remember that. let's talk about first eosinophil. So the eosinophilic lineage actually produces fine pinkish granules in the cytoplasm, while the eosinophil actually produces large, coarse, orange to red granules. Okay, while basophils produces large, coarse granules that will also cover the nucleus. Okay, so yun yung special ni basophil. The granules will also cover the nucleus, in contrast to the eosinophil and neutrophil na they are limited lang to the cytoplasm. Okay, so that's how you differentiate. So when we look at them at the microscope, medyo orangey siya. We call that an eosinophilic cell. So we say that it's a myelocyte because the nucleus is still oval. When it becomes a metamyelocyte, there is now an indentation. So the nucleus becomes like this. Okay? Are you getting the pattern? Okay? The stage of differentiation actually rests on the shape of the nucleus, while the specific identity of the cell will be based on the granules that is present in the cytoplasm. Okay? When it becomes a band, the nucleus becomes very elongated, almost shoe-shaped in appearance. And it becomes a segmenter when the nucleus will now segment. So you will have one lobe, another lobe, that it is connected with each other. So this is what happens. Okay, so that's what happens. So this is now, the segmenter is actually the mature stage that we see in the blood. Okay, so this is the last stage. So everybody getting it so far. The stage of maturation will depend on the nucleus, while the identity of the granulocyte will depend on the granules in the cytoplasm. Okay, please don't forget that. That's how we identify white blood cells. So I've tabulated, and you don't need to memorize this, but I just tabulated the granules that are present in each of these cells. So as you can see, they contain lots of granules. So most of these granules are important in the defense for the body. I'd like to point out the neutrophil, again, I mentioned azurophilic granules, and the specific granules, lysozyme, are the specific neutrophil specific granules. Okay. So function. What's the function of your neutrophil? Again, they are mostly bactericidal. They have a bactericidal activity, and they help in the phagocytosis. So when you have bacterial infection, they go to the site of infection and eat the bacteria if they can. Okay, so they phagocytose foreign particle. They have a bactericidal activity mediated by your hydrogen peroxide, superoxide anion, myeloperoxidase, and the free halogen. So thus, they are important against infectious diseases. So if this phagocytic activity of neutrophils becomes unchecked, or they go beyond the normal tissue, they may cause tissue necrosis, tissue injury, and inflammation. Okay? And the eosinophils, they modulate inflammatory. So they reduce the inflammatory response as they see fit. So as to not over simulate the inflammatory response. And an important factor or function of eosinophil is its anti-helminthic activity. So they generate MBP, I've showed earlier, which is toxic to the parasite and cells. Okay? While the basophils, they have an important function in the immediate hypersensitivity reactions and delayed hypersensitivity reactions. And most of them, they just usually last for about a few days, 3 to 5 days in the blood. So if they are not needed, they die. If they are needed, they go past the capillaries and they go to the tissue, okay, where the site of infection is. So now we go to monocytes. So monocytes are actually part of your reticuloendothelial system. It also has a role in the defense against microorganisms, including mycobacteria, a causative agent of TB, fungi, bacteria, protozoa, and viruses. So you call it a monocyte when it is found in the blood, but when it migrates to the tissues, you will now call it histiocyte or macrophage. Okay? So this is an example of a monocyte. Actually, see monocyte, they only have one nucleus, and their classic appearance is that they have very thin, almost lacy cytoplasm. I don't know if you can imagine it. Very thin cytoplasm. As you can see in this picture, it has few granules, and the nucleus is actually parang folded. Can you imagine a brain? It's parang brain-like. I don't know, this is not a good drawing, but yun, it's folded in appearance. This actually is just one. Okay, now we go to the last important cell, um, lymphocytes. So in the fetal life, lymphocytes originate in the bone marrow, but as they mature and their selection to either become a T cell or a B cell will actually depend on what organ they go. So they may go to the thymus and become T cells, or they go to the bone marrow and become B cells. So this on the right is a picture of a lymphocyte in the blood. So the lymphocytes are actually the smallest white blood cells. They are almost the size of an RBC. So question, di ba, Doc, you've mentioned earlier na the larger the nucleus, the more immature the cell is. So actually, the nucleus is not large in this picture or in lymphocytes. It's just that they really have very scanty cytoplasm. So it's nothing against their nucleus. They appear large kasi they only have scanty na cytoplasm. So so let's differentiate T and B cells. Actually, your lymphocytes are really the backbone of your immune system, your acquired immune system. T cells actually and their progeny function in cell-mediated immunity. So, si T cell, it has lots of um, parang sub-brackets. You have a CD4 helper cell, CD8 um, CD8 cytotoxic cell, and you have an NK cell, the natural killer cell. But basically, si T cell, when you say cell-mediated, it means that it directs automatically at the foreign invasion. Okay, more like a neutrophil. Si neutrophil, when it sends in an abnormal foreign invader in the body, it attacks. Okay, if it cannot destroy it, monocyte comes to play. Si T cell, the same. So they usually um, involved in hypersensitivity reaction, graft versus host disease, defense against intracellular organisms, and against neoplasm. So the lifespan of these T cells are months to years. While the B cells, the role of the B cell is actually to produce your antibody. So they are involved in acquired immunity. I think this will be discussed later on, I don't know, when you talk about immunity. So B cells will become plasma cell that will produce the antibodies that involve the humoral activity, that is involved in the humoral activity or the production of antibodies. So a little overview lang of humoral or production of antibodies. What happens in antibodies in contrast to neutrophil na if you have infection, if you have bacteria or T cells, that's a foreign object, that's a foreign organism. We will kill it because it's not normal. Si B cell, it's like, I don't know what's a good analogy, but what happens is you get infection. Like for example, in COVID, you get infection in COVID. So your body will get infected, you have your immunity will fight. So after infection, you are exposed to that particular agent. So si B cell, what it does is that it will produce antibodies so that when you get that infection again, there are two things that will happen. Either you will not develop symptoms or the symptoms will now be attenuated because it protects you. So that's why it's called acquired immunity, because you acquired it as you grow old. Okay, so that's basically the function of antibodies, and they are produced by your B cells. Okay, again, where does your B cells develop? B for bone marrow. Your T cells develop in the thymus. Okay, they should be checked and controlled by both of these organs, because if they are unchecked, especially the T cells, if they are unchecked, meaning it has to recognize your own body. Kasi si T cell is very, a good analogy for T cell is it's very war shock. War shock si T cell. If it sees something it doesn't like, it will attack it. Okay, so imagine that if it is left uncontrolled in the body, it will attack yourself. It will attack your own cells. It will attack your own organs. So that is now the basis of your autoimmune diseases. Your T cells, mga war shock man sila, it will attack your own cells. So these T cells actually go to a series of counter check. My good analogy for T cells is that they are parang military. They are trained in the thymus to only attack foreign invaders, not yourself. Kasi if that particular T cell attacks yourself, it will be immediately removed from the circulation. So that's immunity. And actually immunity is or immunology is very good. It's a nice physiology of the immune system is actually a nice topic kasi it's amazing how these cells work. So for the lifespan, si T cells, they circulate in the blood for months to years, while si B cells are actually very short-lived, and they comprise about 10 to 20% lang of the lymphocytes. Question, can you differentiate T cells and B cells in the blood? Answer is no. You can only differentiate them by special stains. Okay, so now, I'm sorry, this is taking long. We'll be discussing now the abnormality. So again, similar sa red cells, the normal values for white blood cells will also depend on the laboratory and the age of the patient. The normal component of the majority or the majority of the white blood cells is actually your neutrophils. Second is your lymphocytes, monocytes, eosinophils, and very rare lang si basophil. But in children, the majority of the white blood cell would be the lymphocytes. Okay? Mas marami si lymphocytes in children compare sa adults. That's a normal. Okay? I'm showing you an adult. So, we go now define leukopenia. Leukopenia is a condition wherein bone marrow produces very little white blood cells. So, leukopenia actually is the same with anemia. The number of your white blood cells are decreased in the blood. So, within 2 days after the bone marrow stops producing white blood cells, patients will have ulcers in the mouth and colon, or much worse, will have a severe respiratory infection. Patients will die in less than a week after acute total leukopenia begins if there is no intervention that will be done. The most common cause of leukopenia would be bone marrow failure, such as aplastic anemia. Di ba remember? So it's killing the source. It's killing the bone marrow. Again, I mentioned this earlier. It may be caused by chemicals, caused by irradiation, administration of antibiotics, or other medications that will cause bone marrow failure. So patients are usually transfused to correct the anemia, and they are given antibiotics to ward off infection. So we go now to leukemia. Leukemia is actually the uncontrolled production of white cells, which is caused by a cancerous mutation of the myelogenous or the lymphogenous cell. So this is characterized by an increased number of abnormal white blood cells circulating in the blood. In the picture, these are abnormal leukemic cells. This one. All of these are abnormal. So for you, mga nice to know, the leukemias may be based on two things. It may be based on or categorized by the immaturity of the cell. We call it acute leukemia if majority of the cell or 90% of the cells or leukemic cells are immature. So meaning, what are the immature cells of your what is the immature cells of your erythroid series? The most immature, your pronormoblasts. When you're talking about leukemia, the white blood cells, it is the myeloblast. Okay? When you say chronic anemia, chronic leukemia, it means majority of the circulating cells or majority of the abnormal cells are mature. Okay, it is not based on the duration of the symptoms, but it is based on the maturity or immaturity of cells. Okay? Leukemias can also be based on what type of cells are involved. I've mentioned this earlier po. You call it myelogenous leukemia if the abnormal cells are of granulocytic, monocytic, or erythrocytic in lineage. You call it lymphocytic leukemia when the circulating abnormal cells are of lymphoid origin, or those if they are lymphocytes. So you combine them together. Diba? Familiar na siya? Acute myelogenous leukemia, acute lymphocytic leukemia, chronic myelogenous leukemia, or chronic lymphocytic leukemia, AML, CLL, CML, ALL. Okay, so that's how we break down leukemia. So again, malignancy of circulating white blood cells. So the effect of leukemia is primarily the metastatic growth of leukemic cells. So when they occupy the blood, the bone marrow produces a lot of abnormal cells. So they may replace the entire bone, which causes cessation of production of other hematopoietic cells. So patients will have anemia, They will have overwhelming infection and bleeding. So question, look, why why do they have infection na they are producing white blood cells? Remember, these are cancerous malignant cells. So they do not function the way that they should function. That's why even if it's ironic, kasi even if you have lots of white blood cells, those white blood cells are trash. They do not do anything for you except to cause havoc. So they replace the bone marrow. They may invade surrounding tissues that will cause fractures, or they may spread to the spleen, lymphoid node, liver, and other vascular organs. And another thing is that they may excessively use metabolic substrates because they are very rapidly developing. All of your amino acids, all of your glucose, everything is being fed to the malignant process. So usually, that's why the patient looks emancipated. So they're very thin, they have very poor appetite, like that. So sometimes that's what kills them. But most of the leukemic patients actually die from infection if not treated properly. So the main mode of treatment here is chemotherapy. So that's all for my discussion. I am sorry it's very lengthy, but these are my references. Guyton is my reference for the physiology, while my favorite book, Henry, is my reference for all of the definition of the cells. Thank you for your kind attention, and have a good day.